frequently asked questions about iron deficiency anemia. What is iron deficiency anemia? Iron deficiency anemia is diminished red blood cell production due to low iron stores in the body. It is the most common nutritional disorder worldwide and accounts for approximately 1/2 of anemia cases. What are causes of iron deficiency anemia? The top causes of iron deficiency anemia are abnormal uterine bleeding, and gastrointestinal bleeding from long-term use of aspirin or other non-steroidal anti-inflammatory drugs, or colonic carcinoma. How is iron deficiency anemia diagnosed? Diagnosis of iron deficiency anemia requires laboratory-confirmed evidence of anemia, as well as evidence of low iron stores. Anemia is defined as a hemoglobin level 2 standard deviations below normal for age and sex. Although iron deficiency is the most common cause of microcytic anemia, up to 40% of patients with iron deficiency anemia will have normocytic erythrocytes. As such, iron deficiency should still be considered in all cases of anemia unless the mean corpuscular volume is greater than 95 femtoliter. A serum ferritin level should be obtained in patients with anemia and a mean corpuscular volume less than 95 femtoliter. Ferritin reflects iron stores and is the most accurate test to diagnose iron deficiency anemia. Levels below 31 nanograms per milliliter is consistent with iron deficiency. Iron deficiency can be ruled out at levels more than 99 nanograms per milliliter. Ferritin is also an acute phase reactant and can be elevated in patients with chronic inflammation or infection. What further tests can be done if the ferritin level is indeterminate? In patients with no inflammatory states and in whom the ferritin level is indeterminate at 31 to 99 nanograms per milliliter, further tests can be performed to ascertain iron status. Values consistent with iron deficiency include a low serum iron level, low transferrin saturation, and a high total iron binding capacity. What is the diagnostic strategy for evaluation of the cause of iron deficiency anemia? The evaluation strategy is based on risk factors. For convenience, these stratified into two groups, namely premenopausal women and men and postmenopausal women. Premenopausal women. Excessive or irregular menstrual bleeding affects 9 to 14% of all women and can lead to varying degrees of iron deficiency anemia. Etiologies include thyroid disease, uncontrolled diabetes mellitus, polycystic ovary syndrome, coagulopathies, uterine fibroids, endometrial hyperplasia, hyperprolactinemia, and use of antipsychotics or antiepileptics. Initial evaluation includes a history, physical examination, and pregnancy and thyroid-stimulating hormone tests. An endometrial biopsy should be considered in women 35 years and younger who have conditions that could lead to unopposed estrogen exposure, in women older than 35 years who have suspected anovulatory bleeding, and in women with abnormal uterine bleeding that does not respond to medical therapy. Men and postmenopausal women. In men and postmenopausal women, GI sources of bleeding should be excluded. Current recommendations support upper and lower endoscopy. In patients in whom endoscopy may be contraindicated because of procedural risk, radiographic imaging with computed tomographic colonography or barium edema may offer sufficient screening. If initial endoscopy findings are negative and patients with iron deficiency anemia do not respond to iron therapy, repeat upper and lower endoscopy may be justified. Additional evaluation of the small intestine is not necessary unless there is inadequate response to iron therapy, the patient is transfusion dependent, or fecal occult blood testing suggests that the patient has had obscure GI bleeding with the source undiscovered on initial or repeat endoscopy. In these cases, further evaluation with capsule endoscopy should be considered. What is the treatment for iron deficiency therapy? Patients with an underlying condition that causes iron deficiency anemia should be treated or referred to a subspecialist for definitive treatment. The patient should also be started on oral iron therapy. The dosage of elemental iron required to treat iron deficiency anemia in adults is 120 mg per day for 3 months. An increase in hemoglobin of 1 gram per deciliter after 1 month of treatment shows an adequate response to treatment and confirms the diagnosis. In adults, therapy should be continued for 3 months after the anemia is corrected to allow iron stores to become replenished. What are the problems associated with oral iron therapy? Adherence to oral iron therapy can be a barrier to treatment because of GI adverse effects such as epigastric discomfort, nausea, diarrhea, and constipation. These effects may be reduced when iron is taken with meals, but absorption may decrease by 40%. Medications such as proton pump inhibitors and factors that induce gastric acid hypersecretion are associated with reduced absorption of dietary iron and iron tablets. What are the options if the patient is unable to tolerate oral iron therapy? Parenteral therapy may be used in patients who cannot tolerate or absorb oral preparations, such as those who have undergone gastrectomy, gastrojejunectomy, bariatric surgery, or other small bowel surgeries. The most common indications for intravenous therapy include GI effects, worsening symptoms of inflammatory bowel disease, unresolved bleeding, renal failure-induced anemia treated with erythropoietin, and insufficient absorption in patients with celiac disease. When should the patient be given blood transfusion? Guidelines often specify certain hemoglobin values as indications to transfuse, but the patient's clinical condition and symptoms are an essential part of deciding whether to transfuse. Transfusion is recommended in pregnant women with hemoglobin levels of less than 6 gram per deciliter because of potentially abnormal fetal oxygenation resulting in non-reassuring fetal heart racings, low amniotic fluid volumes, fetal cerebral vasodilation, and fetal death. If transfusion is performed, 2 units of packed red blood cells should be given. Then the clinical situation should be reassessed to guide further treatment.
Audio Jungle. Audio Jungle.